Hello, everyone. This is Shadi from RSH 2025. I'm really privileged to be with Dr. Asaad Khan to talk about planning for valve and valve in patient with aortic valve stenosis. Dr. Khan, thanks for being with us.
Thank you for having me.
This very challenging case, as we are including low risk and intermediate risk patient outliving their valve. So we are planning for patient might have another valve. So let's go over some predictor of failure and how to
Yeah,
choose these valves.
yeah. So great. First of all, thank you for having me. It's a great meeting, and it's my second time being here, and it always amazes me how Bilgeet manages to collect the best of the best from around the globe to attend and give talks regarding valve and valve. I think, Cherry, as we are moving into the low risk group, and we are sort of saturated with the high and the intermediate risk group. And I think lifetime management of valves is going to be a big issue, both in terms of coronary access, in terms of patients who are undergoing surgical valves right now. And we need to start thinking about what are we going to do with them in 10 years' time or 8 years' time?
Yeah.
Which type of surgical valves should we be putting in now that might help us do the valve and valve TAVIs or TAVRs in 10 to 12 years' time? Regarding my experience, I think surgical valve that is already there, that matters a great deal. We know mitroflow and trifectas are not the best for us as interventionists dealing with those. Leafless is an issue. With trifecta, cracking that valve is an issue. We had a case which we are going to present tomorrow. We had a case of a surgical valve where we did end up put it's very tiny annulus because of the undersized surgical valve that was put in. And again, as you said, the issues that come out of it, not just the fact that if a patient ends up with a smaller valve, a surgical valve in the first place, it limits a lot of options
Yeah.
in terms of what we can do with it. But also because of the patient processes mismatch, it degenerates much quicker because the gradients are already high as compared to the body surface area when they start off, and we are sort of dealing with them much sooner than we would expect for a properly sized valve. And then once these valves present to us, we are sort of in a dilemma because there's only so much you can do
Right.
safely with these valves. It's much safer and much easier to just go in, put in a valve, and come out
Yeah.
and say you've done a fantastic
Yeah.
job. But if it was already an undersized valve, which we know a lot of surgical valves already are, and they give a patient prosthesis mismatch, no matter how well you place a supraannular valve, you are still going to end up with some degree of patient prosthesis mismatch at the end of this procedure. And if you are dealing with somebody whose only comorbidity was that they received radiation to the chest for breast CA and otherwise they're doing fine, you're not looking at somebody who's going to die in 5 to 10 years time. You're
Right.
probably looking at somebody who's going to outlive this valve as
Right.
well. And
One of the challenges of valve and valve is access to coronaries.
exactly.
So, is there any specific planning by CT or by implantation of the valve will help that?
Excellent. Great. So the case again that we are presenting had a small VTC as well. So just for people who don't know, if the metallic part of the or the ring of the valve or the handles of the valve are ending up above the level of coronaries, you have to measure this distance called the VTC, which is a virtual transcatheter to coronary distance. If and what we do is we put in a cubicle or a cylinder, which is the size of the inner diameter of the valve that we are planning to put in. That's all done virtually, and the distance from that particular cylinder to the coronary is measured. And if it is less than 3 millimeters, these coronaries are at a very high risk of obstruction. So there are a couple of ways of dealing with it. Probably a more renowned way or a more commonly used technique is the chimney technique or the snorkeling technique, in which you put in a stent with a guideliner there and you check the orientation of the prosthetic valve leaflets, of the surgical prosthetic valve leaflets around 80% deployment of your supraannular valve and see if it is going to obstruct. Then you have to deploy your stent sort of in a way that it ends up above the level of the bioprosthetic leaflets of the surgical valve. But again, it's easier said than done. You have to, a lot of things can happen. It can still embolize. You have to have a long enough stent that it stays in the coronary. It should be short enough that it doesn't go too high, because the longer it is going to be very compressed in the middle. So that won't last too long. And there was data from Australia showing that no matter what you do with these stents, they are always compressed in the middle. So you're not looking at an amazing solution to this problem when you're talking about long term. Then you can do leaflet modification as well, but that doesn't look after the issue of patient prosthesis mismatch. It doesn't really increase the size of the actual native annulus. So obviously we have to plan, and as you said, CT is the key. You need to make sure if you're going in and doing a high risk procedure, it should last that procedure a lifetime. Last that patient a life.
Yeah. Dr. Khan, thank you so much for giving a very great overview about challenges and planning for valve and valve. Watch these videos and others on your YouTube channel and website. This is Alraies coming to you from RSH 2025. Thank you again.
Thank you.
Yep.